via Claire van der Wijk, your colleague. And I worked on the Drakenstein Child Health Study, doing maternal mental health assessments, and then following that, piloting a parenting intervention, which is called book sharing. And then since 2018, I've been part of various groups developing diagnostic instruments. And also for my sins, I'm a PhD student. So in psychiatry, the big question is, what is normal? So it's a lot easier, I think, in other areas of medicine to define what is pathological and what is physiological. We have different things to contend with. We have to think, what is statistically normal, considering a lot of human behavior falls on bell curves. So we can think about statistically, is this normal? But we also have to consider, is this culturally normal to this person, this specific individual? And also from an evolutionary point, is this normal? So it may be statistically normal to sit in front of a desk for 8 hours a day, but I'm not sure we were exactly evolved to do that. So there are lots of things that we have to consider when we decide what is pathology. So how do we make diagnoses in psychiatry? We unfortunately, as you know, don't have microscopes and blood tests to make diagnoses. We use nosology, which is the scientific study and classification of disease. And this is, we classify disorders based on phenomenology, from the Greek word phenomenon, which is just really studying the individual's lived experience in the world. So we look at signs and symptoms. So symptoms are things that people will complain of. They will say, I feel depressed, or I feel sad. And signs are things that people can observe. So someone will say, my child cannot concentrate while doing their homework. So my talk, I'm going to discuss the two systems that we currently use in psychiatry, and then briefly mention the third system, which is called RDoC. And then I will explain my work, which really is based on applying the CDDR, which is the clinical descriptions and diagnostic requirements from ICD, or if you're working with DSM, then that is the diagnostic criteria, how to apply these things, which is via diagnostic interviews. Okay, so looking at the history, people have been trying to classify disease for a long period, and the French really were the leaders in this area in the middle of the 19th century. Achille Guillard made the first attempt, and his grandson actually convened this international conference for the revision of the international list of causes of disease in 1900 in Paris. And eventually this long name was shortened to the International Classification of Diseases. And then that became part of the remit of the World Health Organization, which was convened at the end of the Second World War. And there are about 180 countries that are member states of WHO. The watershed moment was in 1948, when the World Health Assembly, which is the governing body of WHO, accepted ICD-6 in 1948. Because this was the first time that they did not just have the causes of mortality, but they added the causes of morbidity, so disease, not just death. And they, for the first time, included mental disorders. And they have their philosophy has always been, we want to give broad prototypical descriptions of these disorders. We don't want to be too prescriptive unless we can really prove via science that this is how this disease presents clinically. We are not going to be too precise about it, because we value the experience and the judgment of the clinician in making diagnoses. So the DSM had a different history. It originated in America. DSM stands for the Diagnostic and Statistical Manual. And in the middle of the last century, the Veterans Administration needed to classify all of these diseases that veterans were presenting with at the outpatient clinics. It's almost like shooting people is not good for your mental health. So they did also look at what was happening with ICD. They did consider all the classifications that was happening in the different versions. But the watershed moment in DSM really is what happened in 1980 when Robert Spitzer and his colleagues totally overhauled DSM-2 and published DSM-3. And for the first time, they had operational criteria. So they went in a different direction from ICD. They said, we cannot practice this science if we don't have reliability. In other words, if we're not sure that different clinicians that assess the same patient will get the same diagnosis, or that if the same patient is assessed 2 weeks apart, that the same diagnosis will be made. So we really need to get reliability in the field. And the way to do that is to operationalize criteria. So instead of saying you have a low mood or you have several associated symptoms, they very much specified you need to have at least 4 symptoms, or the low mood has to be present for at least 2 weeks. So things were very operationalized. So it's important to remember that reliability does not always improve validity. Validity is, am I measuring the underlying construct? Is there construct validity? Am I actually diagnosing depression when I'm using these criteria? But at least there was a major improvement in terms of how evidence-based psychiatry was practiced when we knew across the world what we were assessing and diagnosing. And then, so there were 2 systems, and obviously people were communicating with each other. And by the time of ICD-10 and DSM-4, people were convening task groups and saying, should we try and unify these 2 systems, or should we try and converge? Eventually, what happened is they decided we are not going to merge, but we are going to try and have similar broad categories of diseases. And they are written in a way that you can, with a little bit of crosswalking, convert a diagnosis from one system to the other. What's been happening is DSM is more commonly used by researchers, mainly because of the operationalized criteria, and also because of the, at this point, superior diagnostic interviews available. But ICD is a legally mandated health data standard. So WHO member states have to report their M&M data to WHO using ICD. In South Africa, psychiatrists mostly train in and use DSM, but you guys know that when we discharge people, we have to use ICD, or if you claim from a medical aid, you also need the ICD code. So today we have ICD-11, which was published within the last few years, and DSM-5, which came out in 2013. So these systems, they have some important differences, and there are people that are critics and supporters of both these systems. So I'll elaborate on that. I'll give you as an example, DSM-5 did consider adding this disorder called prolonged grief disorder. Now, because they have a different remit, they felt that they don't want to overstep their bounds. They don't want to pathologize normal human experiences, or they don't want to be seen to pathologize that. And so they ended up not adding prolonged grief disorder. Whereas ICD-11 said, well, our remit is a bit different. We care about global mental health. We care about things that need to be studied and things that need treatment to be studied for them. So we are going to add this disorder because it does seem from research that it is something that is distinct from depression. It's also distinct from normal grief, and it's distinct from PTSD. Eventually, DSM-5 TR did add prolonged grief disorder. So there's overlaps and links between the 2 systems. But here is a table that I've devised that really show you the differences. So I've told you guys where we stand in terms of the latest versions, and whereas ICD is published by the World Health Organization, DSM is published by the American Psychiatric Association. Now, the authors of ICD is international, and DSM mainly from the USA. But the reality is we live in a post-globalization world. So of course, the international working groups for ICD contained American scientists. And in USA, they, of course, consult their colleagues all over the world. So it's not that it's that separate. The ICD is much more focused on making sure all mental health professionals have access, making sure that settings like low and middle income countries and primary care are covered, whereas DSM is primarily for psychiatrists, although they are also at this point trying to make to involve psychologists. But they are very much focused on what they see in their high income country and in specialized settings. ICD is, of course, a much bigger system because it encompasses all diseases, whereas DSM is only for mental disorders. As I've said, ICD has these clinical descriptions and diagnostic requirements, whereas, and they are a bit more vague and descriptive rather than prescriptive, whereas DSM has diagnostic criteria. And so they have different aims. For ICD, they need people to reliably and validly report on global morbidity and mortality, and they want global mental health to improve. Whereas for DSM, their remit is similar but distinct, that they want reliable diagnosis of mental disorders in clinical practice and research. Now, the ICD is free, it's freely available, and I'll show you where, but that means that they are under-resourced. So when they, because of this, because they are under-resourced and because they encompass all diseases, it takes much longer for a new version to come out. Whereas DSM is expensive, but at least that means they are well funded. And they, because they only cover mental disorders, they come out with newer versions much more frequently. So what are the controversies in the field? This is the discussions that people have each time that, that these diagnostic classification systems are overhauled and published. To keep in mind, mental disorders are very, very complex. They have a multifactorial etiology. So we are never going to find, like in Huntington's, one gene that codes for schizophrenia. That is just not going to happen. People have complex genetic risk factors, and then during development, they experience physiological trauma like infections and psychological trauma, like let's say neglect or abuse or single events. And they develop in certain ways, and then they present with a cluster of symptoms. And these symptoms are much more complex. They are multidimensional. So looking at something like low mood, it's not just about at what level is your mood. Is it average or high or depressed and low? It also has to do with what is the duration of that specific mood and what are accompanying symptoms. And then there are lots of transdiagnostic symptoms, things like poor concentration, can be seen in a variety of disorders, let's say psychotic disorders, anxiety disorders, mood disorders, and they are all the same endpoint, poor concentration, but sometimes there are tiny differences in how you get to that endpoint. And so we at the moment really have an incomplete understanding, unfortunately, of our field, but so which makes it much more difficult to classify disorders. So one of the controversies is, should we really have two classification systems? I think from a pragmatic point of view, I don't see them ever merging. So I'm looking at what could be the advantages. And I think sometimes it is good to have a two-party system, that people try different things and they see what works and what doesn't work, and they can learn from each other. So in a way, I think that is what we have at this point. Then the conversations people always have are, how do you make distinctions between disorders? So, as you guys will know, in clinical practice, things like different disorders often cluster together, and we call that comorbidity. And so we're not as yet 100% sure, are these varying presentations of something proximally, or are these truly separate entities? it's a lot. We are a little bit at the time when, let's say, something that's like anemia, people would see, oh, okay, someone is tired and they're pale and they're short of breath. Oh, okay, that looks like anemia. But it was only when they realized that, oh, looking at the blood smear, some of the cells are small and this is related to iron deficiency, and some of the cells are big and this is related to folate deficiency. We need to get to that point. But unfortunately, in mental health, that is going to be a lot more complex to get to that point. And then we always have this discussion, what is normal? At the symptom level, what the human experience, how much anxiety really is part of the world we live in today, how much low mood. Some things are, even things like psychotic experiences, people thought that was easy to distinguish, but with epidemiological surveys, it did turn out that lots of people hear voices and have other abnormal experiences that never meet the threshold for schizophrenia or any psychotic disorder. And then at a disorder level, both systems really make use of saying, well, when an individual is experiencing a lot of distress, or when an individual can no longer function in terms of their occupational functioning or their relationships or socially, then we think that this has risen to the level of disorder. So people that sometimes manage, they might have resilience factors, might not be diagnosed as having a disorder. ICD has actually controlled for that by adding now to some disease categories. Are you not functioning well, or are you functioning at an acceptable level, but with considerable extra effort? So they understand that it's very complex to make a decision about when something really becomes a disorder. And we don't want to pathologize all of human experience. We really want to make sure we are identifying separate disease entities, because that is the only way to do proper research and evaluate medication and psychological therapies. So just a side note, I don't know if people have heard of the research domain criteria that's also being developed in the USA. This is a classification system that has arisen out of really the criticism against ICD and DSM, that it's not, that their classification is not based on neurobiological correlates. And so the research domain criteria think about mental health and psychopathology in the context of major domains of basic human neurobehavioral functioning. So they will have things like negative valence systems, and then they will talk about the concept of anxiety, which is worrying about threat, fear, which is acute threat, and then they talk about longitudinal threat and how that causes stress. So they talk about symptoms that are, for us, we would call them transdiagnostic, but really in the human experience, they are one core symptom. And so what they're trying to do is they're trying to look at these experiences that humans have. And they say, whereas in neurology, the disorders are due to specific pathological processes. There's a tumor, there's a stroke. This is an abnormality of brain circuitry. So they look at electrophysiology, the EEG, and they can see how the patterns are for the average person or the normal person when they do things like effortful motivation, and then compare it to people with different symptoms. Functional neuroimaging, studying neural circuitry in vivo. And we are making progress because of the fact that we can now rapidly sequence genes. We can do whole genome or whole exome sequencing, which means we can do genome-wide association studies and see, okay, which genes are more frequent in groups of people that have clinically been deemed to have a certain diagnosis, or not just a diagnosis, let's say, a specific symptom like anxiety. And then, of course, clinical neuroscience is also important, looking at things like attention and executive functioning. So really, we're trying to create biosignatures of disorders. So this is what the researchers are busy with and what I'm excited about, but I think it is still going to be some time before this becomes clinical practice. So I'm going to now pivot to focus more on ICD, because that's what my work entails. And I think it's for South Africa as a low and middle income country, ICD is a useful classification system because, number one, the working groups contain people from Africa, and so it will be more representative. It's free, and we have to report in any way to WHO. So for me, I've been lucky that I get to work on this. So ICD-11, the revision happened over 10 years. More than 10 years probably, and chapter 6 is the mental health chapter. And as I've said, they contain CDDR, and they've done lots of studies. South Africa also participated in these clinical utility studies, where people have checked when they use these criteria to make diagnoses, how easy are they to use, and do they fit the clinical presentation? Can you understand them? Are they useful to communicate with your patient or with relatives of your patient? And service user perspectives were also sought on these clinical descriptions for the 5 big disorders, not for the whole ICD. And so the aim really is that these criteria, these CDDR requirements, will help us make reliable and valid diagnoses, and be able to do accurate health reporting. And that is the only way to do accurate treatment evaluation. So if you need to access the ICD, I've said it's free. You are, as someone who works in mental health, welcome to join for free the Global Clinical Practice Network. So this is the network that was established when the ICD-11 requirements were being tested. They were being field tested. And so subsequently, they have also done COVID studies, getting feedback from all the professionals that are part of this network. So you can either join this network or look on this website. So the whole ICD is here, but chapter 6, you can see, are the mental disorders. So you don't have to read all of this. This is just to show you that the ICD is very well organized. Each disorder consists of these different paragraphs or sections. So it starts off with essential features, which are really the core features of the disorder, the things that you really have to fall into that category. And then additional clinical features are mentioned. There's a paragraph on distinguishing this disorder from what is just normal human experience, the prognosis and how things normally develop with this illness, how this illness might present in children and adolescents, and if there are specific cultural or gender-related features that might alter the presentation. That's also explored. And then this boundary conditions section has to do with the differential diagnosis, making sure you don't diagnose something that's lower in the hierarchy of diagnoses, or not diagnosing something that might be better explained by something else. And of course, there's always this mention in the essential features that you need to make sure this is not due to the effects of intoxication or withdrawal with a substance, or the effects of a medical condition. And then lastly, there are specifiers, like something like with panic attacks. So you now have this wonderful classification system, whichever one you choose, but now you have to apply this in clinical practice or in research. And so how do you do that? So your options are really 2. You can do an unstructured clinical interview, which is you use your knowledge of these systems and you interview someone based on your experience of interviewing patients or participants. Or you can use a structured or a semi-structured diagnostic interview, which is what this second half of my talk is going to be about. These diagnostic interviews have been shown to improve reliability and validity when making a diagnosis, and also to improve the detection of comorbid disorders. So there is evidence to suggest it might be more useful, which is why people in research will invariably use some kind of structured or semi-structured diagnostic interview. In clinical practice, people have financial and time constraints, so it's not routinely implemented. So what are the interviews currently available? So I call these multi-diagnostic because they cover all the diagnoses. People working in specialist areas, let's say something like ADHD or autism, they normally have very comprehensive interviews that are just based on that specific disorder and all its associated features. But these interviews are not designed to cover every single possible feature of the disorder, but they are designed to make sure every disorder that's present is picked up and diagnosed. So the aim is to be both sensitive and specific. So for DSM, you guys will most likely know the SCID. That's often used in research, but lately, because the SCID is very long and laborious and has to be used by experts, people have opted to use the Mini. So if you look at the research, you'll see when people need to make diagnoses specific, and especially if they have large numbers of participants, they prefer the Mini. Then the older instruments that actually cover both of these systems are the SCAN, the Schedules for Clinical Assessment in Neuropsychiatry, and the CIDI, which is the Composite International Diagnostic Interview. So the opinion on the SCAN that I've heard from people is that it's a very complex system and requires a lot of reading, so, and also requires experts, so it's really not used a lot. And the CIDI was used extensively in world mental health surveys, but as of today, the CIDI has not been updated for ICD-11, so it still yields ICD-10 diagnoses. And so here is where I and my team come in. We have been working on ICD-11 based interviews, the SKY-11 and the FLY-11 and the FLY-11 epidemiology, which I will explain all three of these to you. So these are all, in green, these are all instruments that are owned and distributed by WHO. So what is the SKY-11, which is the equivalent of the SCID, but for ICD-11? It is the structured clinical interview for ICD-11. It is semi-structured, which means that people can ask extra questions, or people can opt to leave out questions because we are thinking experts are going to be using this interview. What does this contain? So it contains operationalized clinical descriptions and diagnostic requirements. Because remember, we said that this is one of the strengths of the DSM, things are very well operationalized. And in the past, to get past this issue of ICD-11, in ICD-10, ICD-10 published a green book, which also contained operationalized criteria or requirements. And so this SKY-11 that we're working on really is the equivalent of that. It's aimed at psychiatrists and psychologists, and it's comprehensive. Eventually, it will include all the disorders. It has, via algorithms, you make the diagnoses. There are clearly demarcated skip patterns. There are screening questions and closed and open-ended questions, and you make ratings, which will be absent or present, or absent subthreshold, or present at threshold or above, or things like yes and no. And so this really is going to be the WHO gold standard instrument for establishing ICD diagnoses. So how was this developed? Michael first and an international group got together weekly, and we are still getting together weekly. Someone drafts a module, we comment on it, we edit it, we give it to someone else to review, we edit it again. So it's a long and laborious process. We essentially, remember when I showed you what the ICD-11 looks like? we convert the first section, the essential features, the core symptoms, into questions, and we operationalize these. So we make sure that if the ICD says there are several associated symptoms, we will say, well, a minimum of 3. Or if the ICD says duration of several months, we will say the binges have to happen for at least 3 months, once a week. So we operationalize the ICD. And we make sure that all the information from these other sections that are present in the ICD, things like gender and culture related features, are reflected in the questions. For now, we're only looking at adult disorders. And we also make sure that we consider the differential diagnosis and specifiers. So this is what it looks like. The interview, here are the item numbers, and here's the rating column. And in the middle column, the CDDR is printed so that the person interviewing can look at what's being asked about. And in the left column, the questions are printed. And often you'll see there'll be something in brackets in capitals, and that is when the clinician needs to substitute something. They have to substitute what the patient has or the participant has told them. So it looks very much like the SCID, which is not surprising because Michael First is also the first author of the SCID. And so my PhD is all about testing the SCI-11 in the field. We want to know, we're not yet at checking validity and reliability. We want to know mental health professionals and service users. What do they think about this interview? So we have convened a group of people from all over the world, from a variety of settings, and we have got this questionnaire for them that people have to rate on a Likert scale. And so here are the places that we're going to test the SCI-11. Carrie, Jared, and Pratap are also with me part of the editing group of the SCI-11. And so the idea is that in each country, we get 10 mental health professionals, and if they do 5 interviews each, then we will have 250 interviews. And then the clinicians and the patients rate, was this understandable? Was it offensive in any way? Did it ask the questions that I thought were important? Did it cover all my concerns? Or for the interviewer, the clinician, did it interrupt the development of rapport or not? Did it align with my concept of the pathology? Did it align with the middle column, the CDDR? And then we will get all this feedback and publish the results, and then use that feedback to edit the SCI-11. So, and here are my collaborators. I'm very fortunate via my supervisor, Dan Stein, to work with Michael, who's also, like I said, the first author of the SCID and also works on the DSM-5, and Kathy, who is at the Global Mental Health Program, and Jeffrey Reed was actually the convener and the supervisor, the coordinator of the ICD 10 to 11 revision. But what happened? So I'm going to just leave that picture there. So my trial was delayed, and also the editing took quite some time. And then we also had this thought that, well, the SCI-11 is going to be great, but like the SCID, it has certain limitations because it requires experts, it's time consuming, it's expensive. We don't have that much money, or we might want to do a large treatment trial or a large epidemiological survey. So we thought, here, as you can see, here's another representation of the interviews available. We know that the SCI-11 is going to be the gold standard, and if you do DSM, the SCID, we know the best you can do is this lead diagnosis, which is a longitudinal all data expert consensus diagnosis. But for pragmatic reasons, we need something here in the middle, something that's at the silver level, something that's equivalent to the mini. And so this is why we drafted the FLY-11. like I mentioned, the CD was used in the World Mental Health Surveys, and I'll talk about this in a second. And this intervention, mental health gap intervention guide, is wonderful. It was also devised by WHO, but it's not very specific. So it is designed for people to interview patients and put them in a stream, put them in you're in the antipsychotic stream, or you're in the mood stabilizer stream, or you are in the antidepressant stream, really to address the treatment gap. So it's not going to give you a specific diagnosis, but it's going to facilitate treatment of people. That's better than nothing in areas that are severely resource limited. So we drafted the flexible interview for ICD-11. And why is it flexible? Because you can use different modules, and you can use it just for the current time frame, or you can use it for current and lifetime time frame. We, me and my colleagues, drafted this Fly 11. We convened people from all over the world. We met every 2 weeks, and we edited this Fly 11 and a user's guide. So this took a lot. It was a lot quicker, because why? We did not include all disorders like the Sky 11. And also I had just had 2 years of working on the Sky 11. So I was fortunate to have had that background. And this is the group of people that worked on the Fly 11. We were fortunate that Michael's guidance and operationalizations in the Sky 11, we were just going to copy, because obviously we want the two instruments to converge in the diagnosis that they make. So here's the difference between the flexible interview and the structured clinical interview. In the Fly 11, we only cover common mental disorders and serious mental illnesses. It is almost fully structured, and it only contains yes and no questions. Excuse me. But the operationalizations are identical. Because it does not cover everything, it's going to be a lot shorter. And it's also a lot simpler. In other words, it's designed for use by all mental health professionals and primary care physicians. And so this is not going to be the gold standard. It's not going to be perfect, but it's supposed to be good enough. And what does it contain? You guys can have a look. Aside from introductory sections, we look at the mood disorders, psychotic disorders, anxiety, OCD, PTSD, and complex PTSD is a diagnosis that's unique to ICD-11. Eating disorders, hypochondriasis, drugs, alcohol, and recently we added ADHD and gaming disorder. For suicidality, we do a screen, and organic cause screen. We know even psychiatric illnesses are organic, but we try and exclude things that are caused by medical illness or medications or substances. So we had very many discussions. Who should be using this Fly 11? And we ended up with a vague definition. We said people with a minimum level of clinical experience or of training. And we thought, where can it be used? Research settings and clinical settings. And my aim really for the future was, once we have things like integrated healthcare clinics where people with schizophrenia and metabolic syndrome get seen to address their diabetes and high blood pressure and their schizophrenia. This would be a very useful instrument there. And why would people choose the Fly 11? Because it is shorter than the Sky 11, even though it's not as 100% as sensitive and specific. It's more cost effective than the Mini. It is shorter than the City, which is in any way not adapted for ICD-11. And it's much more specific, like I said, than this mental health gap intervention guide. And so this is what it looks like, the Fly 11. We don't have the middle column with the CDDR. We are hoping that the questions are simple enough that people can see what the requirements are that are being asked about, and people can make ratings in the different columns, and when they get to a diagnostic box, then they know, okay, this is I've made this diagnosis. And then the beginning of this year happened, and we just got inundated with people. I just want to check the time. Expressing interest in this Fly 11 because of the reasons I just said. They are interested in something that's maybe not perfect, but pragmatic and shorter, something that is free, something that's based on ICD-11, which is up to date. And so we had people from France who are interested, who are looking at behavioral addictions. And for them, the Fly 11 that we wrote is perfect because they want to use the Fly 11 to look for comorbidity. They will use much more specialized monodiagnostic interviews to look at the disorders they are studying. But they want to also give their participants the Fly 11 to check, do they also have ADHD, or do they tend to have more depression, or is there any association with anxiety? So for them, the Fly 11 is perfect. But then what happened is we got interest from 3 different countries that told us they are going to do national mental health surveys. And so they will have vast numbers of people, and they cannot afford to pay psychiatrists, psychologists, GPs to do these surveys. And also WHO is doing a STEP survey, which is really a survey about general health, where they do things like check people's blood pressure and their BMIs and do urine samples and blood samples and ask about smoking and sedentary lifestyle. So WHO's STEP survey has just decided they need to add mental health into their survey. So all 4 of these parties, they really needed an epidemiological version of the Fly. And so very quickly, I created a version of the Fly, which is called the Fly Epidemiology. Something that is a lot more rigid in terms of the skip patterns and the optional questions and the phrasing. And because that is completely, there's no freedom of skipping questions or rephrasing questions or adding questions, other than what the program tells you. This is something that now can be programmed into an online platform like Qualtrics and Redcap. And in other words, this is something that can now be, people can do these surveys with mobile devices offline in the field, because these programs have offline capabilities. You enter the data, and once you get to where you've got Wi-Fi, it uploads the data. And so because this is much more prescriptive, it can be used by trained lay interviewers. So it covers all the disorders in the Fly 11, and the original is now known as the Fly 11 Clinical. And so this is what this looks like. So it is on paper a lot longer because it's much more explicit, but it is not for use on paper probably. It's probably for use on something like a mobile device, as you can see on the right. And so in the meantime, what is happening is all of these things have been written, but like the Sky 11, they've not been tested. So in the meantime, we are testing the feasibility in much the same way as we're testing the Sky 11. We're testing the feasibility in South Africa with psychiatrists, psychologists, GPs, MOs, where they use the Fly 11. We want to know from the clinician, but we also want to know from the patient, how understandable and useful is this interview. And we are just awaiting Department of Health approval. Then we will get going. And at the same time, we are working with our very own Prof. John Joe Dawson-Squibb on modifying the Fly 11 for adolescents, and then considering whether to add any relevant disorders. They convened for the first time in 2023, and they've got collaborators from the US, China, Mexico, and India. And eventually we would love to present this to your adolescent advisory board for review. And also a consultant at Falkenberg, Dr. Jay Bauer, is working on the forensic Fly 11. They've decided which disorders to add, as you can see, and they first convened in February. And they are also working with Norwegian forensic colleagues. So all of that needs to happen in the next few years, testing the Fly11 epidemiology in these national surveys, testing the Fly clinical, not just in South Africa, but in other English-speaking countries, testing these adolescent and forensic versions, test and retest reliability and inter-rater reliability and validity, and then doing translations. The good news is we already have a Spanish translation because a colleague in Mexico translated the Fly. And we probably already have a Hindi translation because in India, they have started translating. And the idea is because it's a WHO instrument, it's going to be available for free, but the versions that are on electronic platforms, we are going to have to require a fee just to maintain the platform. But that is my story.
Sure. Thanks so much, Karen. I really see this amazing, important work, but it is quite a lot going forward, but I also see the value. And it seems quite complex given all the different varieties, but I think it will add a huge contribution to especially global mental health going forward, which I think many of us on the call are working in that area. And just before I open to the floor, I find it really interesting to see how context and training really influence our clinical practice, isn't it? So depending on where you're studied, so for example, I studied in Canada and the UK, the DSM was the only thing that we were kind of exposed to at the time. And then working here and in African settings, I actually see the more of the value in things that are, task sharing and open access. And if we don't have that, we really are just making things more inequitable between high income and low income countries, which I find really interesting. It'd be interesting to see what others think of this. So I'd like to open to the floor. I'll also look at any chats. I'll open the chat now as well. Does anyone have any questions for Karen at this time? It's quite a lot happening. Asha?
The good news is I'm not the only one who has to do it. I have lots of very capable colleagues, and WHO oversees the whole process.
Yeah, it's a nice group. Asha, over to you.
Yes, hi, Karen, thank you very much. Lovely presentation. I have a question about how you arrive at the threshold criteria for something to be clinically significant or not. For example, 5 out of 7 symptoms need to be present, or the symptom needs to be there for 3 months or more, etc. How do you arrive at such a distinction?
So a variety of ways. We have made the decision that if the text says symptoms, that means 2 or more. If the text says several symptoms, that means 3 or more, just in order to be consistent. But when we make that decision, we also think about, does this seem reasonable? Is this too sensitive? Is this going to pick up someone who's actually reasonably healthy or not? And we look at the literature, and we are very lucky because the people that worked on the working groups when they were devising the requirements, we have access to them via Jeffrey Reed. So we will ask them and say, look, we are thinking of operationalizing like this. Does it seem reasonable to you or not? And of course, we look at what the DSM has done. So for instance, it's interesting in depression now, the DSM is 4 out of 9 symptoms. But ICD has added hopelessness as a depressive symptom. So in ICD, we now have 5 out of 10 symptoms. But that's actually was specified by the CDDR. We did not have to make that operationalization. But that is one of the few things that's specified. But yes, that is basically our process.
Thanks. Any other questions? Thanks, Asha. Not yet. Well, so Karen, I'd like to, oh, sorry, Asha. Yeah, of course, follow up.
Sorry, am I allowed to follow up if there are no other questions?
Of course.
Yeah. I just have a concern about pseudo-specific criteria, made-up criteria that seem to emerge out of non-empirical directions that make their way into these diagnostic manuals, and I wonder what your thoughts are on how to avoid such decision making if it's based on kind of subjective determinations of so-called of experts, definitely experts, but to what extent can we circumvent error in that regard?
I don't know that we can, unfortunately. I think this is a problem. We have to be aware of the fact that we make the decisions with the best information that we have. Very often we think, okay, we've got this question. For instance, when I mentioned actually hearing voices can occur in people that don't have schizophrenia. We don't have data to know what is the threshold for hearing voices. You know, where does that become pathological? So very often the answer is we don't have that data. And so we have to make a pragmatic decision and say, this is what we're going to use for now. And we have to remind ourselves all the time that this shouldn't be reified. This shouldn't be written in stone, I think. And I'm really hopeful that with more research, with artificial intelligence and better statistical methods, we can answer a lot of these questions. I don't know if you have an idea, please tell me.
No, thanks. That's quite helpful. I think not to reify these criteria is probably something that we all need to keep in mind. Thank you. Very helpful.
Joe, do you have a question? Yeah.
I do. Thanks, Karen, for presenting. I mean, you really sort of pared down a lot of information, and I really enjoyed the history of it as well. I wondered, because you've been in this sort of game for a little while of nosology and trying to categorize things, but so I suppose the question is the tension between research and clinical. So clinicians invariably don't use these structured interviews, despite the fact that they improve reliability and validity, and we want them to use it, and we want to make it as easy as possible for them to use it. But then researchers, like Ashraf's question, which is a really important one, want to make sure that everything is valid and done just correctly, and we get it boxed away as it should be, so that it's useful and meaningful. How do you try and balance the tension between those two groups to come up with an instrument that's helpful, or are you going to tell us at the end of your PhD when you found the answer?
The second one. No, I think it is always difficult because I'm not unaware of the pressure that clinicians face in terms of patient numbers and time constraints and expressed emotion in the room and all kind of things happening. I am hoping that with the studies, on the one hand, that we can show clinicians that it's not that difficult to use a structured interview, and especially when someone is new and training, that can act as scaffolding for their diagnostic practices. So that is my hope. But I'm not sure in the context of current very ridiculously low mental health funding, how we are going to cross that bridge in our clinical practice. For research, I think it's easy that if you want to present your research to a peer-reviewed journal, you have to show a certain minimum level of scientific rigor, and so you don't have much of a choice.
Okay, lovely, thank you. While you were talking about the history of it, there's a lovely book called Saving Normal, if I remember, and I forget the author now, but he was one of the editors, or chief editor for the DSM along the way, and just the struggle of lots of different diagnoses, and are they valid, are they meaningful and useful? Yeah, there's a really interesting book. Thanks, Karen. Good luck ahead.
Yeah, and maybe just to echo what you're saying, John Joe, I think there's also in public mental health, we often have that distinction between the ethic and the emic approach, isn't it? And what you're saying is very much the ethic perspective when we're making diagnosis that will be across all countries, whereas that emic perspective is really about idioms of distress and explanatory models. So often finding that balance is very tricky in those cultural adaptations. So it'll be interesting to see how this moves forward. Any other questions from the floor? Oh, sorry, Karen, did you want to respond or comment on that? Any other comments from the floor, or questions or clarifications? Wonderful. Great. Well, thank you, everyone. Thank you so much, Karen. It was a really wonderful presentation. I think it was really nice and engaging questions. I don't think this will be the end. I think we're going to have to invite you back when your PhD findings are in. We'd love to hear more, and do keep us keep us in mind when you find your findings, and we'll respond and circulate your papers to others. It's really, really exciting work. Thanks,
Excellent.
everyone.
Thanks.
Yeah, and have a great week, everyone. And we will put the recording online for your colleagues who missed it today.
Excellent. Thank you.
Thank you.